Monday, March 14th. It's 1 o'clock, and we'll call to order the Committee on Health and Human Services and Finance. So on our agenda today, we've got just one item. We got the Office of the Legislative Auditor report, and we also have the Director of the Emsrb board as well, some public comment. And so what we'd like to do is take the testimony from everybody, and then we'll do a Q&A after. So Mr. Kirchner, when you're done testifying, we'll have you come back up after the last testifier, and then we'll take a series of questions after that. So with that, we'll start. Our first order of business is Mr. Kirchner. Please state your name and your role for the record.
Thank you very much, Mr. Chair. My name is David Kirchner. I am with the Legislative Auditor's Office. I was the manager for our evaluation of emergency ambulance services.
Mr. Kirchner,
yes.
Could you pull that mic up there and speak directly into it?
I was just about to ask whether or not I was being fully audible. Is that better, Mr.
Much
Chair?
better. Thank you.
All right. I would like to, before I get started, acknowledge the other members of the team that worked on the audit. Catherine Tyson, Ryan Maltz, and Gretchen Becker. Ryan and Gretchen are here with me today. I would like to start off by giving you an overview of the key findings I'm going to cover today. First of all, the process for allocating ambulance services to geographic areas is one that we think needs a look at and some reform. The license renewal process for ambulance services does not have sufficient oversight. There are no state performance standards for ambulance services, and we think that there should be some. There are ambulance services in Minnesota, particularly in outstate areas, that are struggling with not enough staffing, not enough revenue, and we think the legislature should take action there. And lastly, we found that the Emergency Medical Services Regulatory Board, or Emsrb, has not done a good job in fulfilling its responsibilities, and some changes need to be made in order for them to do that. Before I move on to those findings, let me start off with just a little bit of background about ambulance services in Minnesota. As of the end of fiscal year 2021, there were 277 ambulance services in the state. And in that fiscal year, they conducted over 650,000 ambulance trips. These ambulance services have a wide variety of different organizational types. Some are, and now I've just realized I didn't turn my ringer off. Some have paid staff, some have volunteer staff, some are a mixture of paid and volunteer staff. Some services are run by local governments and fire departments. Some are run by hospitals and healthcare systems. Some are run by nonprofit organizations. And there are still some ambulance services in Minnesota run by for-profit entities. So there's a wide variety of organizational structures. There are basically two types of care provided by ambulance services in Minnesota. There is basic life support and advanced life support. And this basically reflects the level of training of the individuals that provide care to the people that are being served. Basic life support ambulances are, patient care is provided by emergency medical technicians, or EMTs. Generally speaking, they have, is there something I need to be aware of, Mr. Chair? Okay, there is, they can provide basic care, a few limited medications, and they typically are served in, provide service in lower population areas. Paramedics are the staff that provide service for advanced life support ambulances. Those are typically in more populated areas, and because paramedics have more training, they can provide more sophisticated care and are able to deliver or administer many more medications. Overseeing this system is the Emergency Medical Services Regulatory Board, or Emsrb. This is a board that is appointed by the governor. It licenses ambulance services and certifies or registers paramedics and EMTs and emergency medical responders. It investigates complaints, it inspects ambulance services, and they also provide some grant funding to regional organizations. So with that bit of background, let me move to the first finding I wanted to talk about, and that is with regard to primary service areas. These are the geographic areas associated with each ambulance service license. They were first created in the 1980s, and ambulance services get a primary service area, and they must commit to providing coverage 24 hours a day with, or ensuring that coverage is provided 24 hours a day in that area. and they cannot deny service to anybody in that area based upon the individual's ability to pay. So it's both a combination of they have to provide service and they have to provide it to everyone. We have in the back of the report maps of all of the primary service areas in the state in an appendix at the back of the report. I'm going to show you one small portion of one of those maps here on the next slide. This is in far southern Minnesota in Martin and Faribault counties. And as you can see, we have dots on here to indicate the cities, including Fairmont and Blue Earth, which are the county seats there. And then the shaded areas represent the areas covered by the ambulance services. And as you will note, these ambulance service, primary service areas are not just confined to one of the key advantages to primary service areas, that it helps to ensure that all Minnesotans have access to ambulances by tying together those low population areas that probably couldn't support a service by themselves with a higher population area. Everyone is able to obtain access to ambulances. However, we think there are some significant problems with this model. First of all, the primary service areas were set up in the early 1980s, and when they were set up, they were not really designed to change with the times. There have been significant changes since the early 1980s in population, in communications technology, in healthcare, in transportation, and yet we're still working with very much with the same, very similar boundaries to what were set up in the early 1980s. Also, there are significant disparities in local control. When the primary service areas were first set up, they were allocated to whoever was providing ambulance service at that time in the early 1980s. So if a city was providing ambulance service or its fire department, then the city had control of the primary service area. If a hospital was providing ambulance care, then it had control of the primary service area. And so these structures then carried forward in time. And so you have these oddities where, for example, St. Paul controls who provides ambulance service in St. Paul, but Minneapolis does not. International Falls controls who provides ambulance service, but Crookston does not. Red Wing controls who provides service, but Owatonna does not. So there are these disparities all around the state. Our recommendation to the legislature with regard to primary service areas is we think the legislature should keep them. We think they do, and they serve an important function in terms of providing access or making sure that there's access for everyone to ambulance services. But the legislature should change how they are created, modified, and overseen. The legislature should develop a process for periodically reviewing ambulance service primary service areas so that they can change with the times. And there also should be a system for local units of government to have some say into who provides service in the area, in their area. I want to move on now to talking about licensing. There are basically two processes for licensing: the initial licensure process and the renewal process. The initial licensure process we thought had a lot going for it. It has a public comment process, and there are opportunities for local government input, but it's almost never used. The vast majority of ambulance services in the state have been licensed for decades, and they simply go through the renewal process. And the renewal process is basically just filling out a form and sending in your money, and you get renewed. There's only been one really brand new service licensed in Minnesota in the last decade. The licensing process also doesn't take into account instances where there are actually changes in provider for geographic areas. Statutes do not require that the initial licensure process be used when a license is transferred from one entity to another. For example, when a hospital is bought out by another entity, and it doesn't take into account when a license holder that does not provide the service itself, but rather contracts out to someone else, when they change providers from one entity to another, or they go from providing the service themselves to moving to a contractor. We think those would be good points at which there should be opportunities for public comment and local government input, and they are not there. So we have two recommendations with regard to licensing. First of all, we think that the legislature should make the license renewal process a little bit more stringent. One possibility, for example, would be to require ambulance services to pass an inspection in order to be able to be relicensed. We also think that the legislature should require that ambulance services go through that initial licensing process whenever a community's service provider changes from one ambulance service provider to another. I want to move on now to talk about accountability. There are a number of standards in state law for ambulance services, but they focus mostly on capabilities rather than on outcomes. What ambulance crews are trained to do, what types of equipment is on the ambulance, rather than on did you do a good job when you had to go into action and provide good service to individuals. Emsrb has the authority to set performance standards, but it has not done so. And we think that it certainly could have done more to do that. However, we also point out in the report that there are certain areas of ambulance service performance where Emsrb does not have the authority to set such standards. For example, response times, how quickly an ambulance gets to the scene of an incident from when the call comes into 911. So we have two recommendations for the legislature. First, we believe the legislature should require Emsrb to set and enforce performance standards. And I will note that that will be a careful process that will probably take some time to do. That's not a simple.
Recording stopped. Recording in progress.
Times and must rely on neighboring services to provide mutual aid because they simply do not have enough people on staff in order to be able to provide coverage at times when calls come in. Sustainability in ambulance service sustainability in rural areas is a nationwide issue. It's not true just in Minnesota. And there are a lot of ideas out there for how to improve it. Frankly, we felt that most of those ideas are untested and unproven. So rather than recommending any of those specifically, we have a broader recommendation to the legislature that the legislature experiment with some of the ideas that are out there in the policy community. But they should be viewed as experiments. We suggest the legislature put into place some things that are trial policies that have sunset dates, or that are pilot projects that occur in some parts of the state and not in other, to see if those are helpful. And then the legislature should monitor whether or not those are making a difference for the ambulance services in those areas, and either continue the policies or perhaps move to new ones if those are not working. Lastly, I want to move to the performance of the Emergency Medical Services Regulatory Board. Frankly, we had some significant concerns about how this board has performed over the last several years. The board has no statewide plan or strategy for emergency medical services in the state. Sustainability issues in outstate Minnesota have been a problem for years, and the board has not taken action on those issues in the last 5-6 years. The board has not updated its rules in over 2 decades. There are rules on the books related to things like communications and radio technology that are far, far out of date and need to be updated. There is a law on the books that requires Emsrb to collect financial data from ambulance services. Not only have they not been doing that, the board chair and vice chair were not even aware that this requirement existed until we asked them about it. The primary service areas are a fundamental part of ambulance service licenses, and yet the board has never published maps of all the primary services area in the state. The maps that we have in the back of our report are the first time that we're aware of that those have been published. The board has not done a good job of overseeing the performance of the agency, of the staff. There has been, the primary way in which that's done is through evaluation of the executive director, but the board has not evaluated the executive director of Emsrb in over 5 years. When the agency was originally formed in 1996, it had 17 staff. The board allowed that to drop to, at times, as few as 3 staff. And as you might expect with that small amount of staffing, investigations were not getting done, inspections were not getting done. The agency was not able to perform all the functions it needed to perform. And this lack of staff was not due to a lack of funds. EMSRB has returned money to the general fund in each of the last 3 biennia. In one of those biennia, it was over $1 million that they returned to the general fund that they did not spend. So we have quite a few recommendations with regard to EMSRB. We think that the legislature should require EMSRB to create a statewide emergency medical services plan that has goals for what are going to be accomplished and when they're going to be accomplished by and who's going to accomplish them. And then EMSRB should be required to come back to the legislature and report on its performance in meeting that plan and update that plan for what's going to happen in the next several years. We also think that the legislature should require EMSRB to evaluate its executive director. That's not something that's normally in the law, but they haven't been doing it. So we think that the legislature should go ahead and require it. We have quite a few recommendations for EMSRB itself. Certainly the board needs to improve its oversight of the agency and ensure that the agency has sufficient staff to carry out its responsibilities. The board should begin collecting the financial data that is required to collect in law. It should be updating its administrative rules, and it should publish primary service area maps and make those available to stakeholders around the state. Lastly, our concerns about EMSRB were broad enough and deep enough that we think that the legislature might consider whether broader structural changes to EMSRB are called for. And this could be in a variety of approaches. The legislature could change the composition of the board. We note that EMSRB has the lowest percentage of public members of any board that we compared it to, so that could be one approach. The legislature could require term limits for board members. The legislature might consider moving some of EMSRB's functions somewhere else, or all of them. One example might be to have the Department of Health, for example, license ambulance services, but keep EMSRB licensing individuals like EMTs and paramedics. Or the legislature could decide to keep the status quo. You will hear from the director of EMSRB that they have taken some action and they plan to take more action, and the legislature might decide to take a wait and see approach. But if you do that, we do recommend that you be monitoring how their performance improves over time. And that you should be asking them to come back to you and show you that they have made the changes that we feel need to be made. And with that, Mr. Chair, I am done with my presentation.
Thank you, Mr. Kirchner. We appreciate the report. So with that, and members, for those that weren't here in the opening, we're going to have all the testimony and then we'll open up for questions. Thank you, Mr. Kirchner. Welcome, Mr. Ferguson.
Good afternoon, Mr. Chair.
Please state your name and your position for the record. And now that you're here in week 5, you've had 2 weeks since we've last heard your report, and we would expect a full detailed report of everything you'll do for the next year. So,
absolutely. My name is Dylan Ferguson. I'm the executive director for the EMS Regulatory Board. As Chair Curran points out, I've been on the job now for I believe week 4.5 is where we're currently at, starting number 5. And it has been a privilege to begin to undertake a lot of different work. First off, as evidenced by the 19 recommendations contained within the report before you, the challenges facing EMS are many. While some of the recommendations and findings within this report are directly within the purview of the EMS Regulatory Board, there are some that are not. However, I wish to state unequivocally that as it relates to the spirit and to the general intent of each of the recommendations put forth by the Office of the Legislative Auditor, the EMSRB agrees. The EMSRB would like to extend our thanks to Mr. Kirchner and Auditor Randall and their team in putting together this comprehensive report. What I want to spend some time doing this afternoon is really focusing on the actions that the EMSRB have taken really even before the audit report came out, but were triggered by when Mr. Kirchner and his team started asking some questions and uncovering some things. So the first thing that I'm happy to report is that the EMSRB has made 6 new hires since June of last year. This includes the hiring of additional EMS program specialists, which are responsible for conducting inspections. In addition, there have been additional investigators put onto staff, which, as their name would imply, are responsible for the investigation and disposition of different complaints. We have also, the EMSRB has also installed a new executive director, which is how I came to be sitting before you today. And as a result of these changes, we have really seen our rate of inspections of EMS agencies has increased dramatically. It is my goal as the executive director to ensure that every single one of Minnesota's EMS agencies has been given a recent inspection by sometime in early Q1 of calendar year 2023, as we continue to build upon the progress that we have already made. In addition, all of the backlogged complaint investigations have been cleared by our team of investigators and have either been fully dispositioned or are awaiting disposition in front of our complaint review panel, which is an entity of the board. Additionally, this is my 4th or 5th legislative hearing in as many weeks. The EMS Regulatory Board is more legislatively engaged than at any time in the agency's history. And for those of you keeping track at home, the agency has been in existence since 1995. Additionally, work on our internal operating procedures continues to be ongoing. And really, that focus is starting with a concentration on the evaluation of me, the executive director. This is something that the board chair, the vice chair, in addition to all the members, take very seriously and recognize that this has been a shortfall of the board in the past. At this point, the process, while still in a little bit of fluctuation, the overall intent is to ensure that I, as a new state employee, am given a performance evaluation at 3 months, 6 months, and 12 months to ensure that I am moving in the direction consistent with the strategy and oversight of the board. Mr. Kirchner highlighted a couple of different factors as it related to performance measures. And performance measures are extremely important. If for no other reason, they help the citizens of Minnesota understand that they are truly getting some of the highest quality medical care of any state in the country. I've spent 30 hours in the last week creating a draft performance measure report to personally examine the type of clinical and quality care that is being provided across our great state. And I am happy to report that in nearly every single measure that I looked at, our EMS system and our EMS agencies and our individual EMTs and paramedics are providing some of the best care that I've ever seen in my traversing the nation as an EMS administrator. Kind of culminating all these different factors, I actually have a meeting later this afternoon to discuss a 41-page work plan that have been put together by the Emsrb staff that seeks to address each and every single one of the recommendations that are within the purview and within the sphere of influence of the board. It is my intent to have this 41-page work plan or some version of it serve as an interim state EMS plan while we undertake additional processes and additional stakeholder input to really put together that comprehensive state EMS plan or strategic plan, if you will, that is sought by the OLA recommendation. As it relates to the mapping of primary service areas, I wanted to touch on this briefly as well. The Emsrb previously had PDF maps of the primary service areas. The OLA is correct that those maps were not previously published on our publicly available website. In addition, because the PSA process was really locked into the old land survey coordinates, they were largely text-based PSAs. However, those text-based PSA descriptions are published on our website. To that end, though, the Emsrb has contracted with Minute to work to create a GIS mapping software mapping file, which upon its completion, we will be able to post that directly on the Emsrb website so that EMS agency service managers, John and Jane Doe public, community leaders, they can see exactly who is designated to provide service within their community. This is a significant investment by the Emsrb of contracting, essentially $100,000 with Minute to get this GIS project off the ground. We have already completed a pilot proof of concept project, and that pilot and that project was well received by the agency. And we continue to move forward in discovery meetings and look to complete that project as quickly as we can. As it relates to the collection of financial data, I will highlight just briefly that section of law that Mr. Kirchner highlighted was separated from the traditional statutes, rules, and regulations that the Emsrb is customarily used to interpreting and looking at. Realizing that there are any number of sections of law, administrative rule that can impact an agency, the board directed staff to essentially compile every single piece of legislation containing the word ambulance, EMS, or Emsrb. Staff undertook a extensive evaluation to ensure that there were no other that there were no other sections of law of which the board or staff were unaware. As it relates to a potential plan to begin collecting that financial information, the specific recommendation highlighted to the Emsrb to begin collection of this information unless the requirement was repealed. I believe that there are probably some arguments to be made on both sides. However, as I come before you today, it is my duty and responsibility to ensure the laws that the laws are enforced as they are written. And if the members of this committee or other members of the House or Senate are interested in additional conversations related to that financial collection of information, the Emsrb is more than happy to engage in those conversations. So those are a lot of the things that are ongoing at the Emsrb right now, and some of our plans for the immediate future. It is our intent to take this audit seriously, and in the spirit of audits and the Office of the Legislative Auditor, we take each and every single one of these recommendations seriously. We look forward to ongoing collaboration with the members of this committee, in addition to stakeholders across the state, as we work to, as we take the time to implement each and every single one of these 19 recommendations. And we simply ask for your engagement, and we ask for the ability to be able to continue to make those changes to ensure that each and every single Minnesotan has access to high quality emergency medical services. And with that, Mr. Chair, I will cede the remainder of my time.
Thank you, Mr. Ferguson. Could you just for the record, so people here, not everybody serves or is on the legislative audit committee, just give two minutes on your background. So you were just recently hired, and I believe from everybody I've heard, they believe that we hired the right person. And so with your background and what you've done in this very area, just 2 minutes, I think it'd be excellent for everybody here.
Absolutely. Thank you, Mr. Chair. So I initially started my career in emergency medical services as a volunteer firefighter, first responder in Central Illinois. I started as a junior in high school and progressed into really working as a volunteer or paid on call for numerous basic life support ambulance services as a way to put myself through college. I received my undergrad from Illinois State University with a major in political science and government with an emphasis in public administration and constitutional law. I worked as a regional EMS administrator of various systems of different sizes. One was a very rural system of one county supervising 3 agencies. Another one was a more suburban metropolitan service in Illinois of 5 counties and supervising about 75 different services. In addition, I also worked as a municipal firefighter paramedic. During this, I began to work on my master's degree. I have a Master in Arts in Emergency and Disaster Management from American Public University System. And for the preceding 4 years before coming to Minnesota, I served as the director of the Bureau of Emergency Medical Services for the Pennsylvania Department of Health, in which I oversaw all aspects of that Commonwealth's EMS regulatory system, including personnel, agency licensure, in addition to education, crafting state EMS plans, and a lot of things with data and performance measures. In addition to all things COVID, it was kind of an all duties as assigned type of position, as I'm sure that many members of this committee are well familiar. So that's a little bit about my background. And for those of you wondering why Minnesota, 2 reasons. One, Minnesota has a reputation of providing some of the best clinical care in the country. In addition, the structure, which has come under a great deal of discussion over the course of the last couple of weeks, is actually a function and a structure that many states are actually working to adopt. And so that is, it was unique. It was something that was interesting. And also, for those of you doing geography, I have 3 children, and they are closer to their grandparents from Illinois. They are closer in Minnesota than they are in Pennsylvania. So that's a little bit about me professionally, a little bit about me personally. And Mr. Chair, I appreciate the opportunity to expound.
Thank you, Mr. Ferguson. And so with that, you mentioned about, as you have a pretty clear path of many things to implement, and you've started to make those changes. And so you recommended a 3, 6, and 9-month report, or 3, 6, and 12-month report. And I think that would be definitely welcome. And I think the chair of the HHS would love that, that report. In addition to, I think I'll recommend to Senator Utke that we convene a hearing in the next, an informal hearing, to get an update in person in the next 6 months. So,
and Mr. Chair, I'd just like to clarify, those 3, 6, and 12 were for my personal evaluation of the executive director. However, to be clear, I am happy to appear before this committee at any time. All you have to do is say a time and place, and I will be there, Mr. Chair.
Excellent. Then let's plan on a 6-month update, and to give us a review of where you're at. And so it will lead up into the next legislative session. So if you have legislative changes based on the work and your discovery in implementing the plans based on what you have, it'll be a great time to work on it. So thank you. So we'll have next testifier, Mr. McAlpin. We also have Vicki Arndt. I don't see her in, is she online? Anyone? I didn't see her. Mr. McAlpin, please state your name and your position and who you represent, and the floor is yours.
Thank you, sir. Buck McAlpin. I'm here on behalf of the Minnesota Ambulance Association, and I'm just an old paramedic. That was a pretty impressive resume to listen to. And the one thing I want to offer is, since 1994, when I began the conversation, some of us with the ambulance medical directors, about forming an independent.
Mr. McAlpin, could you please, microphone, thank you.
Better? In 1994, when we began to start the conversation of forming an independent EMS regulatory board, it really came from a group of our medical directors that we were a division within the Department of Health, and we didn't feel that EMS was getting some due attention to a larger type exposure once we started to really see paramedics and EMS and our career expand across the state. And I found my visit with Mr. Kirchner and his team to be very interesting. And the one thing I took out of the audit, and obviously you read audits, the job of an audit is to bring up some opportunities, is there's a lot of interesting data in there that I thought we knew, but this really validated some things that I think are important to talk about today. And we feel real comfortable with the regulatory board and the way that it's formed. And obviously the board size and things, the industry thinks are good conversations to have working with them. But I think if there's one thing we wanted to extend today, which I think we're hearing from the committee, is not a lot of knee-jerk legislation around this until there's a lot of thoughtful conversation. The primary service area law, I think Mr. Ferguson ended his conversation about our model here in Minnesota. One thing that would probably take the OLA 3 years to understand is the history and how we formed that to really have a group of physicians come up and talk about how we put that together. Because in Minnesota, we don't have a scope of practice for our paramedics or EMTs. We're certified, and we're certified through the regulatory board. That allows our paramedics and EMTs to work under our physician medical directors. And we have a very active group of medical directors in Minnesota that oversee our EMS operations. The formation of the PSA law actually came by an I-team investigation from Don Shelby in the 80s. And if you ever want to look something up and watch that, it's pretty interesting. Because it came out of that we had too many ambulances showing up at a North Memorial ambulance, a Hennepin County ambulance, and Smith Martin would all show up at the same time. And that wasn't a good use of resources. Most ambulance services in the 80s were owned and operated by coming out of the funeral home era, privately, governmental ambulance, as the OLA report talks about across the state. The current PSA law, as the OLA talks about, enacted to stop duplication of services, not to have too many ambulances in one geographic area. The ambulance service would care and transport regardless of patient's ability to pay. Today in Minnesota, the average reimbursement for an ambulance transport is 30 to 40 cents on the dollar, and well below the cost to offer the ambulance service. To assure an assigned license would cover both high volume and low volume areas. Municipalities have volume and revenue, but with that, let's say the city of Marshall, you have a large geographic area outside of that. That was put on the franchise license to be sure those areas were covered too. And most importantly, not to lead to a deleterious impact that the Supreme Court's ruled on in the past that would allow an ambulance service to sustain operation and secure capital and financial viability to stay in business. It's a very capital intensive business. The ambulance overlaps were interesting when I looked at the maps in there too, and I enjoyed the maps. I was good work on the maps. The overlaps are actually not a bad thing. Can the board clean some of those up? Absolutely. But I can think back in all my years, I came into EMS in 1982 as an emergency medical technician. Those overlaps were added over the years to allow other departments, as areas grew, as the OLA report talks about, in volume and population. They said, we can't cover the entire area. I think way back to Divine Redeemer's EMS system, when we started to allow the overlaps with Apple Valley, Lakeville, Farmington, or Burnsville Fire, they allowed other EMS systems to come in and overlap those areas and operate today. In 1997 and 98, Congress passed the Balanced Budget Act. And that stopped all ambulance services across the country to balance bill why the reimbursement is so low. And what that turned into is you saw a large proliferation and consolidation of EMS operations across the country. And one thing the audit showed, which I think is interesting, at one point we had 305 roughly individual licenses. As Mr. Kirchner testified to, there's 277 out there today and 250 of them operating. 77% of all patients transported in Minnesota are provided by Alina, North Memorial, Sanford, Mayo Clinic, Essentia Health, Hennepin Health, LifeLinks Air Medical Division, M Health Fairview, and CentraCare. Another 13%, St. Paul Fire, Oakdale, Cottage Grove, Red Wing, Cloquet, Virginia, Hibbing, Maplewood, White Bear Lake, Burnsville, Woodbury, and International Falls. So 90%, about 21 ambulance service licenses, provide care to every single Minnesotan in the state. As we talk about performance measures and Mr. Ferguson's comments about the type of care that we offer, most of those services are either accredited by the Commission of Accreditation of Ambulance Services, called CAS, or the Commission of Accreditation on Medical Transport Systems. Very rigorous standards they face to get those credentials to operate. And our friends in the fire service follow the NFPA fire standards very closely on response times and patient care delivery. These groups all provide the training across the street or across the state for our EMS responders. The physician medical direction is usually provided by all these large healthcare systems with very little reimbursement for those services. And they also provide the air medical assets in the state. I think you all know a helicopter is about $5 million to put out there. Absolutely, there's downstream support to healthcare systems with it, but that's who puts our air medical assets across the state. And for all that, it's part of the franchise primary service area for ground operations. We in the ambulance industry don't think that EMS should be a risk-based investment model, and the capital money to purchase some of these and how the licensing laws is set up really reflects to some of our private operators that are out there that have owned these ambulance licenses for 40 years. Should they be reviewed? Absolutely. We should be sure people are doing their work with it. And then the other 10% of who provides EMS in the state. Those are the Elgins, those are the those ones that Dr. Klein talked about a few weeks ago, Senator Klein, that he sees comes into the Mayo Clinic. That's the backbone of our EMS system is our volunteers across the state, and it's nearly 60% of them. Even some of these large EMS companies today I mentioned use some of these volunteers in their ambulance systems, and the ones that have the pancake feeds and the fundraisers. And Mr. Ferguson is the first executive director we've had on this board since it was formed in 1995 that has significant EMS background. When the board was first formed, we had an interim paramedic for 6 months. And after that, the state hiring system, in my experience, has been how many master's degrees do you have? Do you have a law degree? I would not somebody not running the nursing board that didn't understand nursing or a physician to run it. We've done a really good job with lawyers and a lot of bureaucrats over the years, but not somebody that just talked to you about what he's put in place in 4 weeks, which is astounding to the industry. The current landscape today, I think what I want to talk about for just another minute here or so, Mr. Chair and members, what's going on with the industry. This Senate, a couple of weeks ago, you guys aggressively moved Senator Lang's bill, Senate File 2876, to allow waivers for ambulance services. We had a problem, which they detailed in the OLA report with staffing before COVID. 60% of EMTs have left the workforce across the state. To say it's a crisis is an understatement. The folks on our ambulance association call Friday said to make that loud and clear. That bill would allow us to have problems with supplies that expires, different types of drivers, some certification extensions. This morning, the House pulled that out in Ways and Means Committee. They said since the audit came out, they didn't feel that they had the faith in the board to administer those waivers. That's concerning to the ambulance industry. They did say they're drafting their own standalone bill, so I don't know what that looks like. So that Senate file left the House over there today with that language out of it. And I'm guessing folks on listening to this will hear that for the first time today. Another piece is back in September, we sent a letter to the leadership of the House and Senate and the governor. We asked for $30 million, $35,000 per licensed ambulance to get money out to these people to do incentive bonuses and anything we can do to try to keep EMTs on the trucks. That didn't get done with no special session. So that's another bill we have of Senator Lang, Senate File 3549. And I know that's a big number. And also in that bill is a fix we've worked on with DHS on Medicaid payments for load leveling between hospitals, not only from COVID, we had a bridge collapse or things like that. And tomorrow in Senator Abler's hearing, we're going to hear a non-emergency rate bill. There is no non-emergency hardly available after 6 p.m. in rural Minnesota. All that work is being dumped on the ambulance industry. And we need to work on mental health capacity. What you're hearing from ambulances across the state, and one of the reasons it's tough to keep our resources up. The association asked me to pass on to Senator Rosa, and this committee heard that bill the other day. They overwhelmingly support expanding mental health and not driving patients across the road. But we just wanted to say, we appreciate the audit. There's really good information for our industry. I think it's safe to say that folks know who the EMS Regulatory Board is now since 1996. And we stand willing to work with the legislature and the regulatory board on making sure things continue to move forward.
Thank you, Mr. McAlpin. So members will do, we have one testifier who hasn't logged on yet. So let's move to member questions. So Mr. Ferguson, if you could come up, and Mr. Kirchner as well. Members and guests. I don't see any hands up. I don't see any on the board. Senator Wickland.
Thank you, Mr. Chair. Thanks for the presentation and thanks for your introduction, Mr. Ferguson. I just wondered, there's really many different diverse areas that these recommendations fall into. And I know that you haven't had very long, Mr. Ferguson, to be, working on this. But I just wondered if you have any thoughts about how you see some of the work moving forward to engage the legislature in the kind of the decision-making process or the ability to design solutions. Because I can see that, like I said, it seems like there's many diverse areas that are going to be touched. And then also, some areas which might be in contention with each other, in terms of what decisions are made. If you could comment on that. And I don't know if, Mr. Kirchner, if you had any recommendations in your report about how the work to, implement some of these recommendations should move forward. That'd be helpful. Thank you.
Mr. Ferguson.
Senator, first off, thank you for the question. As it relates to really the legislative engagement, obviously the Emsrb, by virtue of its ex officio members, Senator Lang and Representative Hewitt, those are our direct links and connections with the respective committees and with the respective chambers. Ultimately, our primary focus is we want to be part of the conversation. We realize that there are things that may need to change. And what we really try to focus on, and what my focus is one on information sharing, right? And trying to convey the perspective of what is coming from the industry, what is coming from our responsibility as a regulator, and also essentially doing that political calculation of what is tenable, right? Because not everything is tenable. And really, that's what I see my job is as the state's lead EMS regulator, is to kind of pull all of that information together and to try to be a resource for any senator, representative, legislative staffer, research analyst, of really providing that information to anyone that I can and offering solutions. The Emsrb has a legislative work group whose primary focus is on reviewing and vetting legislation and making proposals. Just for kind of a point of order, the Emsrb has put forth previous cleanup bills that relate specifically to our statutory responsibilities in 144E. The OLA audit specifically highlighted the fact that that section needs to be updated, and that there are multiple statutory incongruities as laws changed over time, sometime maybe not with the degree of forethought or comparison of existing laws to ensure that those things did not occur. But nevertheless, here we are. And that group is very active. I think because of previous relationships, that group has not been able to be as effective as it could have. And that is one of my primary focuses, is to establish relationships, appear before you in hearings, answer your questions, so that when it does come time for us to put forth a recommendation and put forth a suggestion, that there can be some confidence reinstilled in the members that, you know what, this is something we need to seriously look at. So I hope that at least partially addresses your question, Senator and Mr. Chair.
Thank you, Mr. Ferguson. Senator Whitcomb, follow-up?
No, thank you. I don't know if Mr. Kirchner has any comments about that, but thank you for that answer. I appreciate it.
Mr. Kirchner?
Thank you, Mr. Chair, and thank you for the question, Senator Wickland. I think that what I would say is that there are quite a lot of things that we talk about that are actually the changes that we suggest need to be changes in law, because the information is written into law. So for example, with regard to the standards for license renewal, that's in law, to a large extent. So it's not something that the Emsrb can change on its own. That would need to be a legislative change that would need to be made. And that is true for a number of the recommendations that we make, is that what has been put into place is in law. And so there needs to be ongoing conversations between EMSRB and the legislature to determine how to move forward. Because there are a lot of things the EMSRB would not be able to change on its own. There are some things they can change on their own, and we point certainly to their role as a rulemaking agency, and they have not really taken advantage of that over the past 2 decades. And that is, you know, as a rulemaking agency, they ought to be able to be making rules and changing things that they have the power to change. But there are many things that would require legislative action in order to change, because some things are in the statutes.
Thank you, Mr.
Does that answer
Ferguson.
your question, Senator Wickman?
Mr. Ferguson, or did you want to add something?
I did. Thank you, Mr. Chair. So as it relates, and this is an area that I don't think that I hit on very heavily in my testimony, but as it relates to administrative rulemaking, I believe that the primary concern of the board in the past has been one of cost. Obviously, members are aware of the potential costs related to state agencies as part of the administrative rulemaking process. One of the primary things that I have been spending some time in is reviewing the Minnesota Administrative Rulemaking Manual, which has any number of cost estimates. In addition, there's a specific process I have learned under the Administrative Procedures Act, which specifically relate to the repeal of obsolete rules. And I believe that that is one item which Mr. Kirchner, in referencing the communications equipment, I fully believe that that would be an example of and subject to that Chapter 12 process for obsolete rule removal. So that is the first area of my focus. As it relates to, you know, some of the funding that comes from the EMSRB and what gets returned to the general fund in some of the previous biennia, in review of some of the fiscal reports, we also determined that while there was some general fund money which was returned in each of those biennia, it's also important to understand that regional grants and other types of earmarked funding, whether that be our regional programs, whether that be our Cooper Sam's legislation, which is our longevity payments, those also contribute to the amount which is returned to the general fund. And statutorily, the EMSRB is prohibited from utilizing them for any other function as outlined in legislation. So while I am certain that there was probably some general funding which was returned, the amounts I would stipulate sometimes were not available to the EMSRB for a function such as administrative rulemaking. Once we complete a process of being able to identify if there are these obsolete rules that we could repeal, it is my intent to really kind of shepherd and lead the board towards a more comprehensive rulemaking update. However, I'm also conscious of the fact that there may be, there may be other changes to the legislative landscape in this session or in future sessions. And being a good fiduciary, it's something where, focus on repealing obsolete rules, but ultimately if there are additional statutory changes which are made after the fact, that could potentially necessitate reopening the rules process and re-engaging in those expenses. So the purpose of my strategy is to repeal the rules that need to be repealed, in addition to being a good fiduciary of the funds that we do receive from the legislature. And for that, we thank you. So, Mr. Chair, thank you.
Thank you, Mr. Ferguson. And with that, members, before we take any other question, we do have the last testifier is online. So, Ms. Arndt, if you could turn your video on, unmute your phone, and then state your name and who you represent, and then the floor is yours.
Hi. We're Christopher. I'm Dr. Christopher, and this is my wife, Vicki Arndt. We represent IOTA Ambulance Service in rural IOTA, Minnesota, just outside of Rochester, Minnesota. I thank you for this opportunity to address you and to perhaps bring just some of our rural observations to this table that might perhaps add some fire to your bellies that might help you to drive what we're asking for. So I truly do appreciate our regulatory board. They are there to help us to essentially try and define and redefine what our service areas are. What are the rules and regulations that the legislators that you all have helped put in place to ensure that the best quality of care can be provided to the citizens of Minnesota, especially rural Minnesota. I guess I'm kind of biased that way. I agree that the EMSRB does need to be more involved with our overlaps. We do have a lot of ambulance services in Minnesota, and it's wonderful that we can have 10-minute response times to many of the areas within the state. However, we do see that there are areas that we have even longer response times in the hours. I think if the Emsrb could do a stronger job and have the tools and the resources necessary to help us to clarify those, to help us then to have those conversations to allow for some consolidations in those areas, not to say that we're going to get rid of people, but we're perhaps going to expand the umbrellas of those areas. I agree that there is a lot of reasons that EMS is struggling. Burnout is by far and away a word that you've heard, and it happens in all industries. Within our industry especially, we see it not because that people are just tired, but because people experiences the stress and essentially the human horrors that people essentially put themselves through. Post-traumatic stress is something that is real within EMS, certainly under-recognized, certainly not funded in terms of ways to try and bring people out of the darkness and out of the stress that they feel, and perhaps might add to the longevity within our practices. You know, I love that rural EMS is to be involved in the Emsrb. I think our representation might be a little bit on the lean side. I think perhaps we should have greater representation. And I think that with the use of technologies, that we might be able to bring more people into the fold of those particular meetings, because as a rural EMS person, I'm on call. You ask me to be to a state meeting, a regulatory meeting, I have to find somebody who I don't have during the daytime hours in order to cover my time for me to come give my views, my opinions, and my support. Other things that we need to want to talk about is pancake feeds cannot fund an ambulance service. I'm sorry, you can have all the pancakes you want, it just doesn't do it. Cupcakes, pancakes, raffle tickets, I don't care. We've washed cars, we've had auctions, we've done 1,000 different things. And I can tell you, 2,000 here, 5,000 there, great. It helps me to buy a piece of equipment, but it doesn't help my operating budget. I've had to convert over 26 years of my time here from an all volunteered, non-paid, to at least providing a small stipend to individuals to cover call time, to now actually providing a little bit of something for when they do respond to a call, far below any minimum wage that you might be having. But that's what I'm only able to do because my operating budget is reliant upon the donations, the contributions, and in the rare instances, the actual taxation that may or may not come our way. Which brings up, wonderful that we can have potential taxing districts. But as was just mentioned, legislation to essentially assign taxing districts so that it isn't a choice. It isn't a, hey, you guys need to come together and somehow find a way to say that it's okay for us to spend some money on this. That means you need to recognize us potentially as essential services for the good or for the bad that may be coming. We also recognize that we do have a need for that rural coordination. We do appreciate our regional programs. For us, the Southeast Regional Program under the direction of Don Hauge, as well as we see the South Central, we see all the other regions or the central regions, we see those directors having great influence and ability to address our needs locally, but you're giving them seatbelt dollars to try and fund their programs. And seatbelt dollars only work when you have people who have the time to pull people over for seatbelts. It's an aside, it's an extra, it's a, hey, I'm pulling them over for something else. And as a result, hey, and you don't have your seatbelt on, so I'm going to fine you. So those dollars coming in barely keep anything afloat and don't allow them to expand or to address the regional needs that each of us have. I'm just trying to wrap this up quickly by saying, again, I very much thank you for your time. I know that we're just a small voice in rural America covering 60% of the calls for the state. But as a result, we know that your influence in terms of helping us to be able to maintain our practices is critical and vital. Please look at this report in detail. I know there's a lot of information. I read through it, not to its entirety, but to a good extent. And I found that the information was accurate. If there's questions that my wife and I can address, please feel free.
Thank you, Mr. Arndt. We appreciate your testimony. And with that, members, we have Senator Nelson.
Thank you, Mr. Chair. And Mr. Arndt, I just thank you so much for taking the time to be with us today and to talk about the EOTA ambulance service. I know that you and your team have saved countless lives in my Senate district. And I want to thank you for that. And I also want to note the professionalism that we see there. And I just want to really add on to that plea to make sure that our ambulance services are funded fully. You know, they are the most efficient, timely way to get help when needed. And we think about community paramedics. And then I also just want to acknowledge the stress of the ongoing trauma that you rush into. But I just know how much more difficult it was during COVID, especially those times when you would be rushing into homes you did not know or buildings, and you just didn't know. We didn't know. We had no vaccines, no therapies, didn't know if the COVID virus was present there. I just want to really tip my hat to you, my heart of gratitude, and really to all of our EMS services who have just been right at the forefront during this entire time of what we are saying was a pandemic. Now it's been called an endemic. We want it to stay that way, not revert back to a pandemic. And we just thank you so much. And we know that those, especially in rural Minnesota, Mr. Chair, those ambulance services play an even more important part. So I just thank you for being here today and know that your words are well heard. Thank you.
Thank you, Senator Nelson. Members, Senator Lang.
Well, thank you, Mr. Chair. Thank you, members, for indulging my presences today. I really appreciate that. Both a big thanks to the Emsrb board for being willing to be here, and the OLA for the report that I know a lot of work went into, a lot of time and research, obviously. Upwards of a year, I believe, correct? So we have a big problem in front of us as far as emergency medical services are and the Emsrb is concerned. I think we have kind of enlightened our path a little bit as we go forward, and both with a new executive director and hopefully a little guidance from the OLA. I know that Mr. McAlpin, talked about a knee-jerk reaction, and the fact that we don't want to have a knee-jerk reaction. Unfortunately, as a body, that's kind of what we do here. We react in a knee-jerk fashion, one, because we just don't have the time to truly get into the topic. And when we do get into the topic, oftentimes we still make that knee-jerk reaction. So I can tell you in reference to, and I do have some questions coming up, but in reference to things like the PSA, I was, before I ever made a public statement about it, I was inundated with calls and emails about don't touch the PSAs, leave the PSAs alone. And I think there's a lot of justification to that. I think there's a lot of reasoning for that. I think the PSAs exist for one, to ensure that ultimately that we make sure that the grandpa and grandma get picked up, that our neighbors get picked up by an ambulance or EMS service. So I guess the questions would start somewhere along the line of PSAs. Let's throw that out there. They haven't been reviewed since 1980. For example, right now, when a PSA is in debate or possibly needs restructuring, how does it go about right now? How does that process take place?
Mr. Ferguson.
As it relates to the PSA process, Senator Lang, it primarily relates to what was the underlying reason, what triggered the need to update the PSA in the first place, right? So that kind of goes back to one of the recommendations contained within the report as it relates to kind of transfer of those PSAs and the transfer of that licensure. So that's one component of it. The other section that you run into as it relates to a PSA is essentially, is it a transfer or is it because a service that currently controls the PSA is vacating, right? Saying that we're not going to cover this area anymore. Statutorily, they are required before they can abdicate that PSA in its entirety, they do have to provide some degree of written assurances that it is going to be covered by someone. Ultimately, what will happen though, if a PSA is vacated, in almost every instance, It is the surrounding services which will kind of begin to absorb that territory. However, it may not go through that formal initial licensure process. And I believe that that is something that the OLA kind of makes that point in their report, that they would like to see that initial licensure process utilized more frequently. As it pertains to that, and while in concept, I think that sounds good. There is a little bit of a cautionary tale, which I would just try to educate the members, is that if entities have to go through that initial licensure process, then there is a financial disincentive to them for doing so. Might that dissuade them from actually stepping up to assume that PSA that's going to be abdicated? I'm not saying that in and of itself is, a reason not to look at utilizing that initial licensure process more. As the executive director, I take no opinion as ultimately I report to the board. But in terms of that information sharing that I kind of highlighted to Senator Whitland, that's what I'm trying to do here this afternoon, Senator Lang. So it really depends on what was the reason for the need to change the PSA in the first place. And the fact that so many PSAs have not changed since 1985 when they were first implemented actually speaks to a degree of the sustainability of the type of system that we have. When we take a look at ambulance service closures across the country, you look in any other state, ambulance agency closures are off the charts. In the Commonwealth of Pennsylvania, where I came from, our number of EMS agencies fluctuated frequently. And really, it came to whether or not they were able to make a financial go of it. While there may be some downfalls with those things not changing over a significant amount of time, the fact that so many services have been in business that long and have been able to sustain their operation, I'm not necessarily certain is inherently a bad thing. Do I think that there is usually always a potential middle ground where we can try to take the best from column A and the best from column B and end up with option C? Certainly. But I would just, kind of behoove you that the fact that services are sticking around, I can't sit here before you today and say that is a bad thing. So I don't know if that entirely answers your question, Senator, but if you have a follow-up for me, I most certainly try.
Mr. Kirchner, do you have any comments to add today?
Yes, thank you, Mr. Chair. I think a really important point to make in terms of the way that we framed our recommendations is that primary service areas only change if the ambulance service requests a change. The Emsrb does not have the authority to step in and say, well, this service area has gotten too big, or this service area doesn't have enough people in it anymore, or anything else like that, right? So we have some primary service areas, and I don't want to say that I'm picking on anybody particularly here, but I'll just give some examples, all right? Let's take North Memorial's ambulance service. It's the entire northern half of Hennepin County. The population of that area has changed quite significantly since 1981. There are a lot more people there than there were in 1981, and yet that's still one service area. Now, I do not know, and I think it's a good question to ask, at what point do we say, hey, there's a lot of people there, maybe we subdivide that into 2 or into 3. And I'm not trying to pick on North Memorial particularly. We could say the same thing about Alina and Anoka County, or Mayo and Rochester, or a lot of other places, right? And then we also have areas where there are ambulance services that are serving extremely small populations. And maybe the population has gotten smaller. Maybe the hospital that was right in the middle of that service area once upon a time isn't there anymore. And so having the service area centered around a hospital that isn't even there, maybe that doesn't make as much sense as it once did. But there's not a process by which Emsrb has the ability to step in and say, from a public health standpoint, we think that we ought to rethink the service area boundaries. That isn't the way it works. The way it works is that the ambulance service themselves have to come and request to Emsrb that, well, we'd like a change in our boundary. And I think the things that Mr. Ferguson was just saying about instances where, for example, services close down and so forth, that I agree with him 100%. But I think our broader point is that we have a system that was put into place and wasn't designed to change with the times. And so when you have changes in population, when you have changes in transportation, there are highways there that didn't used to be there in 1980. There's healthcare changes now. There's telehealth in ways that didn't exist in 1980. In fact, the primary service areas were put into place, as Mr. McAlpin stated, back in an era when you simply had a call that went out on the radio, and whatever ambulance service wanted to responded to that. And so you might have 3 ambulances showing up. That doesn't happen anymore, in part because we put into place 911 statewide. And so now the call goes into 911. 911 dispatches a single ambulance service. And so the concern that was once there about having multiple services arrive to the same place, to some extent, has been addressed by changes that have taken place in other forms of technology. So we're still working with a system that was created for an era that we no longer have. And we think, we're not saying that it, necessarily the right choice is to subdivide North Memorial. Maybe it should be bigger. But we do think that there is a point, there should be a conversation around what best serves the citizens of Minnesota with regard to public service areas. And let's not just simply stick with the boundaries that we've had since 40 years ago.
Thank you, Mr. Kirchner. Senator Lang?
So I think you both know what my next question is going to be now, right? And I think probably Mr. Kirchner isn't going to be able to have an answer on this one, but when it comes to PSAs, there's significant financial investment into these PSAs from service providers, right? They pay millions of dollars. This is a tangible item. It's something that is of a lot of value. It's something that's a lot of, it really means something to the communities that are serviced by these PSAs. So the question is, how do we review these in a mindful manner? How does the Emsrb, given the authority, if this legislature was to give the authority to the Emsrb, how do you do that? How do you avoid the conflict of interest of having 28 individuals on the board that have some sort of financial backing from one of those service providers? Now, that's a big question.
Mr. Ferguson?
So since it's a big question, Senator, allow me, if you would indulge me, to kind of deconstruct it and try to go point by point.
Sure.
I believe that, just for the record, I think you said 28 members, probably said in jest, but I believe we currently sit at 19, and I think that includes our ex officios. I'm just a stickler for numbers, Senator Lang.
Sure.
You'll learn that about me.
I round things.
So with that administrative point out of the picture, you bring up one interesting point, and it relates to conflicts of interest. I believe that one of the recommendations contained in the OLA report was to specifically outline what constitutes a conflict of interest. So as it stands today, there are many board members where they may not formally declare a conflict because a conflict may not actually legally exist within the current definitions of whether it be the state's open meetings law or the conflict of interest provision contained within 144E. However, that being said, there are many members that, to avoid any sense of impropriety, will still recuse themselves from a vote. I think, to your point, I think there could potentially be a discussion as to a more comprehensive definition as to what constitutes a conflict of interest, and I believe that was a recommendation that was contained in the report. But to speak frankly and candidly, if I may, for just a moment, there has to be the standard to which you want an individual or an entity to be held must exist. It is difficult to hold oneself to a standard which isn't written down, or the fact that they are being held to the standard which currently exists, but to go above and beyond it. So I think that would be the first component, is to really take a serious look at what constitutes a true conflict of interest. I think that would be step one related to kind of your discussion. As it relates to how you could potentially do this if the legislature so chose, I think that it's a case of, I think size and population is a poor marker, although probably one of the easiest ones to be able to implement. What I base that on is the fact of, and I will just use the North Memorial argument or example just to kind of expound upon Mr. Kirchner's remarks, is that if a service area's population is growing, that in itself is not an issue, so long as they continue to make the investments needed to be able to continue to serve that area. That is an area in which a lot of people will look at response times, which the OLA has eloquently pointed out in their report. The Emsrb has zero authority, none. Performance measures, there are slight disagreements in interpretation as to what authority the Emsrb truly has with performance measures and what actions we could or could not take. But the one thing that the Emsrb and the OLA are in steadfast agreement, that outside that initial licensure process where you're establishing a new base of operations and you have to be able to get anywhere in your PSA within 30 minutes, we don't have that authority. You could certainly look at that, but then I would also highlight that not every single call for service requires a rapid lights and sirens response. We know that there is misuse of the EMS system in Minnesota. We know that not every single contact requires a lights and sirens response to be there within 5 minutes. Are there certainly calls and indicators of that? Absolutely they are. But EMS has evolved more than just a number on a piece of paper. We have systems that are statically deployed, where an agency will deploy ambulances, not just in their base of operation or their substation, but they'll go post on the corner of 1st and 3rd because 3 other ambulances are out. And based on the predictive analytics, they can tell you where the next call is going to be because they have crunched 20 years worth of data, and they know with a high degree of probability that that next call is going to be at 333 First Street. But there are any other number of things that you can consider. You could look at the number of available ambulances per an adjusted capita population. You could use considerations such as I think public input, even to an extent. It's right. It's like, so what is what are the expectations? Existing law today already allows local municipalities to establish their own performance expectations for licensed EMS agencies serving their municipalities. They are subject to the approval of the EMS Regulatory Board. I am aware of only 1, maybe 2, and that's just because of my lack of history. There have been some municipalities which have engaged in that. But to date, I am not aware of any instance where the Emsrb denied a municipality's request for additional performance measures specific to that community. So that's how I would answer that portion. I think it would really have to be multifactorial, Senator Lang. There would have to be some type of objective criteria, some type of subjective criteria in terms of a qualitative analysis as to the unique needs of that community. And I will just close with this, that there's an old adage that says, if you have seen one EMS system, you have seen one EMS system. And that relates specifically to the unique characteristics and the unique needs of each individual municipality or county or region or area being served. To come in with a top-down approach that says it must always be done this way, that can sometimes be a challenge. So I don't believe I have fully answered your question, but I have provided you with as much information
As you dare.
as I, well, actually as possible, as much as I can pull out of my brain at this particular moment. So thank you, Senator.
Thank you, Mr. Ferguson. Senator Lang, a quick follow-up. We have one more question. Senator Nelson's next.
Thank you, Mr. Chair. And well, we know those primary service areas were designed to make sure that there's access. Everyone in our state has access to our emergency services. And I appreciate the report today. And I have to say, I was getting a little concerned as I thought I heard the idea that, well, some ambulance districts have gotten so large that that's a problem. And of course, my immediate hat went on to think, well, no, the real issue is response time, quality of care. Are people getting the services they need when they need them? And so, Mr. Ferguson, your comments reassured me that that is the case. And that should be our metric. That should be our metric. Are people's emergent needs getting served, and are they being served in a timely manner? And so I hesitate when I hear something like a one size fits all. I hesitate when I hear something decide just about the size of population. And I don't know, and one, I appreciate the report, the OLA report, significantly. I think this is very good information to have, but I would be very concerned if there were any sort of, it's very complicated. And if there's any effort to rush something through this session, I would be very cautious of that, because we want to make sure that we have all of the information. We are not doing a top-down, one-size-fits-all, and that's going to take time. And it's going to take time knowing the metrics of all of our ambulance districts and how they're serving the people. So I appreciate the report. I'm glad we're on the way to better implementation, perhaps of the board is what I'm hearing. But if we're talking about changing those PSAs, I would be very cautious of doing that in any sort of a rushed manner without adequate input and time.
Thank you, Senator Nelson. And Mr. Kirchner, do you have a comment?
Very quickly, thank you, Senator Nelson. I just wanted to point out that our recommendation is not to change PSAs, but rather to create a process by which they can be regularly examined to see whether or not they are still serving the public health needs of Minnesotans. In other words, they shouldn't just be kind of stuck wherever they are at. But if there is a process to examine them, and the conclusion is that they are currently serving folks very, very well, and then they should be continued. But that's the point is not necessarily to recommend changes to PSAs. The point is to recommend that there should be an examination of them from time to time, and they don't just kind of live on forever without being re-examined.
Thank you, Mr. Kirchner. Senator Nelson.
Totally agree on that issue. And I anticipate that type of metric will become more evident as we go forward. Thank you.
Great. Thank you, Senator Nelson. Senator Lang, you got a quick follow-up?
Thank you, Mr. Chair. I do, and I know we're running a little short on time here, within 6 minutes. So I guess I'll just make kind of a closing comment and get a stay tuned message out there. But ultimately, there's a lot of things that we need to break down into the OLA's audit. I think, again, we have the right path chosen, I think, with the executive director, and I'm going to put a lot of faith into you. I think this committee and the legislature as a whole is probably going to be doing the same thing. We do expect a little bit more closer engagement. I think you've already shown that you're perfectly willing and able to do so. We did talk about more stringent licensing. I know the director and myself have spoken several times on what that licensing looks like. I know there will have to be a legislative change on that to require either longer, shorter license periods, more stringent, whether they be so or not. Ultimately, I think turn back of dollars is a concern to me, especially when I know that some of those dollars were supposed to be implemented in grants to some of the small EMS services out there that we really need, that why we're here on a daily basis. And then, of course, the board itself. Do we need a restructuring? And as we go forward, I appreciate any input both of you shall have on the board size. Other than that, members, I again appreciate the time as I'm sitting here and babbling on. But at the end of the day, you don't know how much you need EMS services until you need EMS services, and then it's one of those investments you don't get to see until the last day. So thank you.
Thank you, Senator Lang. And I don't see any other questions. And with that, I'd like to thank our testifiers and Mr. Ferguson. Thank you for the detailed responses and welcome to, hopefully you'll finish out week 5 in a great term. And Mr. Kirchner, thank you and the OLA and your team for the work you've done. With no further business before us, the Committee on Health and Human Services, Finances and Policies adjourned. Thank you, everyone.